To better understand this objective, you have to look at it in two perspectives. The first thing is that in a child with hypertension, what makes you think that this hypertension is essential hypertension? And what makes you think that this hypertension is secondary hypertension? Number two, after confirming that the child has secondary hypertension, how will you distinguish the individual causes of secondary hypertension? Now, I need somebody to remind me. When we started the class, I said something unique about essential hypertension in pediatrics. Can somebody remind me about that? Essential hypertension in pediatrics. Which group of people are more likely to have essential hypertension? Very young children or adolescents? Which people?
Adolescents.
Adolescents.
So
greater than 10 years.
So now let's get into it. Sure. So I have a question for you. I need somebody to read a question for me, please. I need somebody to read a question, please. I need a volunteer. Yeah, please read it.
You are evaluating a child in the clinic. You suspect secondary hypertension. Which of the following is likely true? Choose as many as apply. A, it is more likely to pick up secondary hypertension in a 4-year-old child. B, it is more likely to pick up secondary hypertension in a 16-year-old. C, diastolic hypertension is more likely to be associated with secondary hypertension. D, nocturnal hypertension is less likely to be associated with secondary hypertension in children. E, obese children are more likely to have secondary hypertension. F, children with secondary hypertension are often asymptomatic.
You see, Dr. Bruni is a wicked examiner, right? If you were in the CDM,
Yes. They are too close.
But that is exactly how the exam is. You know, it's exactly how the exam is. You go like, oh my goodness, what is happening here? I think I know this, I think I know that. Remember, this is a CDM and you can choose more than one answer. So what answers are you going to go for? And after that, we get into the teaching point. I told you today, I want to really have time for you and really dive into this. So please have all the time for me. Is it more likely to pick up secondary hypertension in a 4-year-old child? Hello? Is it more likely?
No.
Good. So that means A will not be your answer, right? A is not an answer for you. B, is it more likely to pick up secondary hypertension in a 16-year-old child?
Yes.
Yes.
So, you see, now you see your confidence is coming. Okay. Number C, we've not learned this, but I'm going to teach it very soon. In fact, I was discussing these cases with a colleague, and the colleague was like, Brony, you are too wicked. Like, you know, why don't you teach the concept first and you bring a question? And I was like, no, I want to usually bring the question first because these doctors I'm teaching, they are very smart. And then after that, we teach the concept. Okay, so C, diastolic hypertension is more likely to be associated with secondary hypertension. Is it true or false?
True.
Good. Okay. D, nocturnal hypertension is less likely to be associated with secondary hypertension.
False.
False. So that means that D is not correct, but C is correct, and B is also correct. Okay. E, obese children are more likely to have secondary hypertension.
True. False.
We look at it.
Yes.
False. Children with secondary hypertension are often asymptomatic.
It's false.
That's why, because with secondary hypertension, most of the time there's a cause: pheochromocytoma, Wilms tumor, neuroblastoma, coarctation of the aorta, and all of these people, like renal artery stenosis, and all of these people, they may have a symptom or two. So what are our answers? Our answers are: it is more likely to pick up secondary hypertension in a 4-year-old child, and diastolic hypertension is more likely to be associated with secondary hypertension. Now, let's go to the teaching point. How do you distinguish between primary and secondary hypertension? I can hear papers flipping, and I really like that. Please write your point down. I can hear papers flipping. Okay. So now this table is super important because remember that the objective was saying you should be able to distinguish who has primary hypertension and who has secondary hypertension. Number one, we learned that it is more likely to see secondary hypertension in children who are younger. So secondary hypertension is more likely in children less than 10, less than 6, all right? Very young children. It is more likely to see secondary hypertension in them. That's the first thing. Post-pubertal, that is adolescents. It is likely to see primary hypertension in them. So I'm on the second slide. I'm on the second line. Diastolic hypertension is more likely associated with secondary hypertension. Nocturnal hypertension, that is blood pressure, which goes up usually in the night, is more likely associated in secondary hypertension. Obesity is usually associated with primary hypertension or essential hypertension. And then family history, more likely in children with family history of hypertension, that is essential hypertension. You may have some people with secondary hypertension who may have a family history, but family history is usually not common in children with secondary hypertension. But one case where you may want to ask a family history of secondary hypertension in children who have secondary hypertension is polycystic kidney disease, that's PCKD. And in terms of presence of underlying symptoms, essential hypertension, usually they are asymptomatic. And that is why we say that hypertension is the silent killer in adults, because usually the person may not have any symptoms. So doctors, please make a table right now, write out all the differences between essential hypertension and secondary hypertension, or primary hypertension and secondary hypertension. So if you are asleep, Dr. Froza, if you are asleep and I wake you up, okay, or Dr. Joyce, or Dr. Abdul, if you are asleep and I wake you up, or Dr. Majid Koya, if you are asleep and I wake you up and I tell you, please tell me the differences between primary and secondary hypertension so far as adolescents are concerned. You should be able to recite which one is more common in pre-pubertal, which one is more common in post-pubertal, which one is more associated with diastolic hypertension, which one is more associated with nocturnal hypertension, which one is more likely to be seen in children who are obese, which one is more likely to be seen or strong predilection for family history, and which one may or may not have symptoms. With this table,
Dr. Browning,
one key objective.
I have a question.
Yes, please ask your question.
Okay, concerning obesity,
Yeah.
I know most people that have sleep apnea syndrome, OSAS, they tend to be obese, and I think that is a secondary cause of
That's true.
hypertension. Am I correct?
That's true, but
Okay.
I'm listening.
So, you bearing that in mind, I mean, that was one of the reasons why I thought obesity would be more associated with secondary hypertension.
But there are a lot of obese people who don't also have obstructive sleep apnea.
Oh, okay.
And I've seen some tiny people who have obstructive sleep apnea. And at times, obstructive sleep apnea is not only because of obesity. It could even be due to hypertrophic tonsils.
Oh, yeah. Okay.
I got you there.
Thank you.
It could be because of hypertrophic tonsils.
Yeah.
So you can see tiny Dr. Bruni, huge tonsils. And then you see Dr. Oh, this cannot be obstructive sleep apnea because he's not big. No. He can have obstructive sleep apnea because his tonsils are big. He can have obstructive sleep apnea because his tongue is big. He can have obstructive sleep apnea because he has an airway abnormality. But it is true. At times, many people who are obese may also have obstructive sleep apnea. And that is why, if you remember last week when we were discussing obstructive sleep apnea, we said that what is one thing you would do in any patient with obstructive sleep apnea? Do you remember? One thing. Do you remember?
Check your blood pressure.
No.
Measure the neck. Measure
Measure the
the
neck
neck
circumference,
yeah,
of course.
yeah.
Measure the neck
Measure the neck
circumference. Come on.
circumference.
Measure the neck circumference. So please, not everybody with obstructive sleep apnea is obese. And not every obese patient has obstructive sleep apnea, right? Okay, good. And we'll discuss all those things in detail. So remember that I keep bringing the slide up, keep bringing the slide up, keep bringing the slide up. Because of all that we've studied and all the things that the objective is saying, I can glean from the objective that don't miss renal artery thrombosis. And what did I say? Renal artery thrombosis in a newborn. Usually, how will it be presented? That newborn who had umbilical artery catheterization. Exactly. Number 2, coarctation of the aorta. Number 3, congenital renal disease. Number 4, renal artery stenosis. Number 5, essential hypertension in children. And number 6, renal disease in children. And we've learned that essential hypertension in children is usually found in adolescents. And it's also found in children who are obese. Doctors, please, are we all on the same page?